Hello class, this is your Saturday lecture. Today we're looking at chapter 24. Alright, our objectives for this lesson are to explain the effects of the spinal cord injury, describe the diagnostic tests used to evaluate spinal cord injuries, and related responsibilities, explain the physical effects of spinal cord injury, describe the medical and surgical treatment during the acute phase of spinal cord injury. Anatomy and physiology of the spinal cord. So there are some good examples of what a spinal cord cross-section looks like. I'm not able to display them in this meeting, so I will just have you look at your book, maybe while I'm talking about this. All right, you will see a picture in your book of a spinal bone. Okay, it'll look like a sort of large round area, and above that it will have sort of a triangle shape opening. All right. The round part of that is solid bone. Okay, and that's going to be called the body of the vertebra. All right, and those bones that are sort of making that triangle shape are going to be called the lamina. All right, and the opening in that area is what your spinal cord is going to go through. Okay, and the spinal cord goes through your spinal column all the way until the vertebra L2. All right, and then your spinal cord stops. Now it continues to have some nerve fibers continuing, but it is no longer the spinal cord. All right, and those nerve structures at the bottom of the spinal cord are called the cauda equine. That means in Latin, horse's tail, because they thought those fibers sort of look like the hairs on a horse's tail. All right, between the bones of the vertebra, you have a spongy structure called the vertebral disc. All right, the outer part of that structure is very fibrous and strong, and then in the middle of that structure, you have a gel-like substance. All right, the purpose of the disc is to be a shock absorber between each of your spinal bones. All right, if anything goes wrong with that disc, if it gets out of shape, where we might call that a herniation of the disc, all right, anything like that happens, you're not going to have as good shock absorption. And if the disc does sort of herniate and poke out beyond the bones of the vertebra that they're sitting in between, it can actually poke out enough to push on a nerve in your back. And so that's why people have back pain sometimes when they injure their disc or they have a herniated disc. All right, this within the spinal cord, okay, there's a nice cross section in your book where you can see sort of a butterfly shape in the cross section. All right, that's going to be the gray matter, that butterfly shape, and then surrounding it is the white matter. What's the difference between gray and white matter? White matter, the nerve fibers in white matter are surrounded by a fatty tissue that helps insulate those nerves. All right, and the gray matter doesn't have that covering. All right, so that's sort of the difference. All right, cerebral spinal fluid circulates through the brain and the spinal column, bathing and protecting the entire central nervous system. All right, so the cerebral spinal fluid, it flows through your brain. It also flows down through your spinal cord. All right, your spinal cord cavity is continuous with your fourth ventricle of your brain. All right, so spinal fluid flows throughout your brain. When it gets into the fourth ventricle, and a ventricle is a hollow space filled with fluid in your brain. Okay, it's going to get to that fourth ventricle, and then it's going to flow through your spinal cord. All right, your bony vertebral column consists of 33 vertebrae. Okay, and your spinal cord goes most of the way down that column of vertebra, but it does end at L2. All right, the bones and also the nerves of your spinal cord, they're named according to the vertebra that they are, or for the nerves, what vertebra the nerve is exiting the spinal cord at. All right, so we could say L2, that would refer to the vertebra. It might also refer to the nerve coming out of that vertebra. Okay, pathophysiology of spinal cord injuries. Okay, so we classify them on the type and where the location is. So we can classify them according to which vertebra or nerve the injury has happened at. For instance, I might say that you had an injury at C4, okay, and that would be a neck injury at that C4 spinal bone, also C4 nerve tract. All right, so we can say it's at your C4, maybe your T4, okay, maybe your S2, right? All right, so the C stands for cervical, so those will be bones and nerves in your neck. T stands for thoracic, that would be the bones and nerves in your chest. And then S is for sacral or sacrum, and those would be the nerves that come out right about your sacral area, right? So some of that horse's tail, all right, or cauda equine, okay, we'll continue down to your sacral area. All right, and if you were to damage nerves in that area, all right, you might have some problems with bowel control, bladder control, and even your ability to feel sexual sensations. All right, so we can classify them on location. We can classify them whether they're opened or closed. Now, when we had our chapter on fractures and bones, we said what open and closed meant. Okay, if you had an open wound, the skin would be damaged. There'd be a cut or a wound, and you would see structures underneath the skin, right? Okay, in a fracture, we might see a bone sticking out of an open wound. All right, but an opened wound is just the skin has been broken. Okay, so we can classify a spinal cord injury as open if the skin is broken, as closed if you just had a spinal injury and the skin stayed closed. What sort of spinal injury could you have where the skin stays closed? Well, you could have a compression fracture. All right, that's a fracture that happens when your spinal bones are very weak. Maybe you have osteoporosis. And then you step off a curb, or you maybe even riding in a car and go over a bump, riding a bicycle, go over a bump. And the pressure from that on the spine actually causes a spinal fracture. All right, what could be an open wound? All right, maybe a gunshot. Okay, maybe a motor vehicle accident where the skin is opened, but you also have a spinal cord injury. All right, we can also classify an injury based on the extent of damage. We could say it was mild, severe, okay, extensive. All right, you guys, we could also classify an injury whether it's partial or complete. Okay, if we were to sever the spinal cord completely across, that would be a complete transection of the spinal cord. If only part of the spinal cord were cut, we would call that a partial transection. All right, with a complete transection of a spinal cord, you're going to lose all sensation and muscle control below that transection. Now, with a partial transection, you might gain some function below that injury. You might have some sensation, you might have some motor control because it's only partially cut. All right, so when we're taking care of somebody that is suspected of having a spinal cord injury, one of our priorities is to immobilize the spine. And that's so we don't cause any further damage. If they do have a partial transection, we don't want to turn that into a complete transection because we're moving them and pulling on those spinal nerves. Right? So we want to immobilize the patient, immobilize their neck, maybe even their thoracic spine, okay, their lumbar spine, okay, until we can get them to a hospital where we can do CT scans and MRIs and things to find out where the injury is and how bad the injury is. Okay, the effects of spinal cord injury. All right, so wherever the injury is, wherever the transection is, all right, you're going to have loss of control for whatever that nerve tract controls and all the nerve tracts below it. So you guys, the nerve tracts, those are the nerves coming out of your spine in between your vertebrae, okay, at about L5 in your neck, all right, those nerve fibers are coming out of your spine. All right, so if you were to injure yourself at C5, not L5, C5 in your neck. If you were to injure yourself at C5, you would lose all control for any nerves coming out below C5. So you would lose control of your arms, you could lose control of your legs, you'd be what we call a quadriplegic. All right, quadra for 4 because you wouldn't be able to use your arms and legs, your 4 limbs. All right, but you would be able to breathe on your own, probably, if you injured your C5. Because control of the diaphragm happens at C1, 2, 3, and 4. All right, so you lose all control below C5, but you'd still have control with things above the injury. All right, and since 1, 2, and 3, and 4 control your breathing, As long as you don't injure C4, you're going to be able to breathe. Okay. But if you have an injury at C5, all right, you will likely still be able to breathe. An injury at C4, you will probably not be able to breathe. All right, which would mean that you'd be on a ventilator, okay, for the rest of your life if you had a complete transection at 4 or above. All right. So you guys, I would write that down, okay. An injury at C4 and above would mean you cannot breathe. On your own, you'd need a ventilator. All right, even an injury at C5 may interfere with your breathing a little bit, but you'd be able to breathe on your own. You just might not have some use of your intercostal muscles, which also help you breathe. But you'd have control of your diaphragm, and that's your main breathing muscle. All right, so on a ventilator at C4 and above. Okay, maybe a little bit of difficulty breathing at C5. You may need frequent respiratory hygiene and things like that, where we help you get rid of maybe secretions in your throat, things like that. All right, so important to know, what injuries at what part of your spinal cord are going to cause certain impairments. All right, so remember, anything above C5 is going to be respiratory impairment. All right, we're going to skip over spinal shock, and we'll come back to it because we're going to talk next about autonomic dysreflexia. Now, autonomic dysreflexia is something we have to worry about at T6. All right, if you have an injury at T6, okay, or below T6, all right, you're going to be at risk now for autonomic dysreflexia. What is autonomic dysreflexia? This is an overstimulation, overreaction of your sympathetic nervous system. All right, your sympathetic nervous system gets triggered, and usually when that happens, sooner or later, your parasympathetic gets stimulated to calm the sympathetic nervous system down. Now, with the spinal cord injury, your parasympathetic isn't functioning. Okay, it can't calm down your sympathetic system. All right, so any irritation, any pain, any discomfort is going to trigger your sympathetic nervous system. All right, and that's your fight or flight. What happens in your fight or flight? Well, your heart rate goes up, your blood pressure goes up. Okay, you may sweat a lot. All right, all these different things. All right, so once this is triggered, it may cause blood pressure to go way too high, maybe even into hypertensive crisis, that high, right? Okay, it's going to cause the heart to beat very, very fast, tachycardia. All right, so if the blood pressure and the tachycardia aren't dealt with, it could cause a lot of serious problems like heart failure. Okay, it puts you at risk for strokes, maybe even blood clots and things. All right, so we don't want to trigger this autonomic dysreflexia. All right, so with our spinal cord injuries, all right, at or below T6 or at or above T6. All right, we have to be careful of things that might cause irritation to the patient. This is pain, obviously. All right, so if a patient is having foot pain and they don't know it because they have a spinal cord injury, no signals are getting up to the brain because the spinal cord is cut in half, all right, at that level of T6. All right, the pain signals will still get to the spinal cord. They just won't travel up to the brain. And our reflexes are in our spinal cord. And so our sympathetic nervous system will be triggered with pain. Okay, and then we'll get that high blood pressure, we'll get that tachycardia. So we have to get rid of painful stimuli and treat patients for pain, even when they can't feel it in their brain, because their spinal cord will still react to it. All right, and anything that's discomforting will also trigger autonomic dysreflexia. So we have to make sure they're not lying on a wrinkled sheet or lying on a Foley tube. All right, if they don't have a Foley, we have to make sure they don't have a distended bladder, because they won't feel the discomfort of a distended bladder in their brain. But that signal from a distended bladder will still go to the spinal cord and cause autonomic dysreflexia. Okay, it will cause elevated heart rate and blood pressure. All right, so if a person doesn't have a Foley, we may have to in and out cath them to relieve their bladder symptoms. Okay, we may have to use one of the Doppler machines that checks residual urine in the bladder. All right, to make sure they don't have an overfilled bladder. All right, so we have to do a lot to prevent autonomic dysreflexia, and that means taking vital signs fairly often, so we know when the blood pressure is going up. We know when the heart rate's going up. All right, another thing that patients have a problem with when they have spinal cord injury is spasticity. This just means that the muscles are spasming. Now, the patient won't have muscle control below their injury. Whatever nerves feed muscles below their injury, they're not going to have control of those things. All right, and so the muscles will be flaccid, okay, when there's no spasms happening. All right, but for months, sometimes years after the injury, patients have to deal with muscle spasms. Now, after a spinal cord injury, if a patient sees his foot move, he might think that, hey, he's getting some return of use of his muscles. And he might get all excited about that. Hey, I can move my foot. But we have to let the patient know that is just muscle spasms. It doesn't mean you're going to get function back. You're going to get use of your foot back. It's a normal thing. Muscle spasms most of the time will occur after a spinal cord injury. All right, now sometimes the muscle spasms can be painful. And once again, the patient might not feel that pain, but it might cause autonomic dysreflexia. All right, so we have to treat those muscle spasms. Now, we could give pain meds sometimes, but more likely the patient is going to be on an antispasmodic medication to stop those spasms from happening. Now, if the patient can't take oral medication, they might have a device that gives them medication through a blood vessel. All right, it might be programmed to give them so much automatically throughout the day. All right, if a patient were to have something like that, a nurse might, call it a pump with whatever medication it has in it. The most frequently used medication is baclofen. The pump is supplied with so much liquid baclofen medication. And it would give so much to the patient, every so many minutes or so many times per hour. All right, so we would call this a baclofen pump because it has the medication baclofen in it. All right, so you might see a lot of patients with baclofen pumps if they've had their spinal cord injury for a while. All right, so now we're going to go back to spinal shock. All right, spinal shock is something that happens when you get a spinal cord injury, but you don't have the spinal cord cut in half or partially cut in half. You don't have a severed spinal cord. All right, in this sort of injury, maybe the spinal cord is just bruised. All right, something hit the spinal cord in a motor vehicle accident or some other injury. All right, and when you get bruised, of course, you get inflammation where that bruise is. You might get some bleeding where that bruise is. All right, so we're going to have an immune response to that area, and that means inflammation. Okay, but luckily with spinal cord shock, the spine isn't severed. All right, so this will mimic the signs and symptoms of a severed spinal cord. Okay, and we'd need an MRI or something like that to tell the difference between spinal cord shock and a spinal cord injury where we have part of the spinal cord cut through or all of the spinal cord cut through. All right, the good thing about spinal shock is you will eventually recover and you will gain back your function in your spinal cord. All right, but at first it has all the same symptoms. Someone might be flaccid below the injury. They might have muscle spasms below the injury. And they're going to have all the same problems that a severed spinal cord injury patient would have until that spinal shock, that swelling starts to go away. And then they'll have slow return of their function in their spinal cord. All right, so what are the things that can happen with spinal cord injury, whether it's spinal cord shock, whether it's severing of the spinal cord? Okay, well, you're going to have impaired sensory and motor function for everything, all right, below that injury. All right, most spinal cord injuries, all right, you're going to have some problems with bowel and bladder function. All right, to various degrees. Okay. All right, so on page 445 in your book, you'll see a list of cord level injuries. All right, and for most every cord level from C1 all the way down to S5, sacral 5, every one of them lists bowel and bladder difficulties. All right, so that might mean anything from having trouble starting a bowel movement, starting a stream of urine, to you can't empty your bladder, you can't start a bowel movement without some help, right? And some patients do need help with a bowel movement every day. Okay, if they have use of their arms, they can do it themselves. But if not, if they've lost, use of their arms, they may actually need someone's help, a family member or a nurse, to help them stimulate a bowel movement. All right, and you guys, that would be called digital stimulation. Okay, your fingers are called digits, and therefore it's digital. All right, and the person that's going to help out would put maybe the first tip of their finger into the anal area, and they'd move it, and this would most of the time stimulate the person to have a bowel movement. All right, so they might need help with that at home, right? Maybe a spouse or a parent might be helping them out with that. All right, but most patients will have some impaired bowel and bladder function. All right, because they will lose muscle control and sensory control, okay, below the injury. All right, they will lose muscle control below the injury and sensation below the injury. All right, so the effects of spinal cord injury. All right, as we said, impaired bowel and bladder function. All right, impaired temperature regulation. They may have trouble adjusting to temperature. All right, they may be too warm all the time. Okay, or maybe they're cold all the time. All right, so we want to keep a close eye on the temperature of the room. All right, we want to make sure it's a temperature that helps them with their temperature regulation. All right, if they're too hot all the time, we make the room a little bit cooler. Okay, most of the time room temperature, all right, 70 to 74 degrees would be good. All right, impaired sexual function. All right, can also be an issue. All right, because those sacral nerves are going to be involved. Impaired skin integrity. All right, because if you can't feel when a bed sore is happening, you can't feel the pain of a bed sore, you're not going to know it's there. You're not going to pay attention to it. You're not going to have somebody look at it. Okay. All right, so because you can't feel your skin, you're at increased risk for bed sores and impaired skin integrity. Now that could be bed sores. It could be, if you don't have good control of your bladder, it could be things like urine from incontinence. All right, but we're at impaired risk for breakdown of our skin. Okay. Disturbed body image, of course. Your body isn't functioning the way you would like it to. Maybe now your body doesn't look the way you want it to. Maybe you don't like being in a wheelchair. You don't like how that looks. All right, so disturbed body image. All right, the notes down here at the bottom say a complete injury cuts all descending and ascending tracts. All right, the result is disruption of all voluntary motor and sensory activities below the level of the injury. All right, so you guys, your ascending tracts are bringing impulses from your skin and other sensations up to your brain. So you guys, you won't feel anything below the injury because those ascending tracts will be cut off. All right, and you guys, you won't be able to move anything below the injury because the descending tracts are cut off. The descending tracts, that's where your brain sends messages to your muscles to have them move. And since you have with a spinal cord injury, those signals being cut off, you can't move anything below the injury. Because the ascending tracts are cut off, you can't feel anything below the injury. Now, I said earlier that if someone has a partial severing of their spinal cord, they might keep some movement or they might keep some sensation. All right, because maybe the ascending tracts weren't cut. So they have sensation but not movement. Or maybe they have movement but not sensation because the descending tracts were cut. All right, so they all have partial use of things below the injury with a partial severing of the spinal cord. Okay, medical treatment in the acute phase. All right, well, the most important thing is to save the person's life. Now, you guys, if we have an injury above C5, okay, cervical, C for cervical, right? 5 for where those nerves are. Okay, they're coming out of that fifth vertebra area. All right, we said that these people are going to have trouble breathing. So the first thing is to save their life. Get to them fast enough to give them rescue breaths. All right. Hopefully someone's nearby and can start life-saving measures. All right, if this happens to somebody, they have an injury above C5 and no one's around, or they don't know to give the person rescue breaths, all right, the person's probably not going to survive more than a few minutes. Remember, our brain starts to die when it's deprived of oxygen for 4 minutes. It doesn't leave a lot of time. So someone has to find the person and know enough to give rescue breaths. All right. Now, you guys, a famous person that had a cervical injury above C5 was Christopher Reeve. He was the guy that played Superman in the older movies. All right, he had fallen off his horse during a sporting event, and there were paramedics there for the event. And they started, life-saving measures right away as soon as he fell off that horse. All right. So he was able to live, okay? But he was on a ventilator for the rest of his life. He couldn't breathe on his own. All right. He was in a wheelchair for the rest of his life. He couldn't use his arms. And, basically anything below his neck. Couldn't use his arms, couldn't use his feet. All right, but he did live, and he spent his life in a special wheelchair that allowed him mobility. Okay, it was a motorized wheelchair. And strapped to the back of the wheelchair was a ventilator. And he had a tracheotomy hooked up to the ventilator. All right, so he was awake, he was alive, he was breathing, he could move around. All right. He could even talk with special devices. All right, and he lived quite a long time. All right, because he was a wealthy person. He had made several movies. All right, and he could afford all the things that he needed. All right, survival rate is not very good for this sort of patient. But he did have excellent care and he lived a long time. Now, what will cause someone usually to die after this type of injury is that they will get pneumonia. Because even with the ventilator, there's not really good clearing of secretions and things made by the lungs. All right, I'm sure he had great therapy from respiratory therapists and things, and they probably helped him clear secretions. All right, but he did end up passing away from pneumonia. all right, after several years. And that's due to the inactivity. He wasn't walking, okay, and he had trouble clearing his secretions out of his lungs. And that's a common reason for a lot of patients to pass away. They have problems with respiratory issues, all right, and they eventually get pneumonia, and that's what kind of does it. Okay, their body can't deal with that pneumonia. All right, our first priority is to save their life, of course. So we're going to run over there and give rescue breaths if needed, if the injury is that high up, right? C5 or above. All right, our second priority is preventing further cord injury. So you see somebody with a spinal cord injury, all right, after making sure they're breathing or giving them rescue breaths, they're going to put on maybe a specially made collar for their neck to keep their spine of their neck still, or maybe something on the neck and the torso. All right, they may have a board that they put on the patient, under the patient, okay, to lift them up and transport them. That will keep their thoracic spinal column nice and straight, okay, and different braces and things so that the spinal cord doesn't move. All right, when you have a spinal cord injury, whether it's a severing of the spinal cord, whether it's bruising, like with spinal shock, all right, both of those conditions are going to cause an immune response, okay, and that means swelling. And you guys, if swelling doesn't go away, all right, if it's chronic, if it's there for a long time, swelling can actually do further damage. All right, so it's very important after spinal cord injury to give them drugs that will reduce the inflammation, all right, and maybe prevent cellular damage, all right, prevent further damage to the spinal cord. All right, so what are our most effective anti-inflammatories? You guys, this would be steroids. All right, so we're going to give the spinal cord injury patient, whether it's spinal shock or spinal severing, all right, of the spinal cord, we're going to give them steroids. Now, the most often steroid used is called methylprednisone. All right, and it's going to reduce the inflammation. All right, so that's part of our preventing further cord injury, okay, giving methylprednisone or some other steroid, okay, and keeping the spine very still and straight. Now, you guys, this might mean, especially if it's a neck injury, that we put the person in traction. All right, and in your book, it shows you a couple different types of traction. All right, one is called the Gardner-Wells traction. And with this traction, they drill holes in the skull to attach some tongs. All right, and they're going to attach these tongs to the head, and then they're also going to attach the tongs to a weight and a pulley, right? So there'll be a cord, maybe a chain, some sort of pulley system attached to a weight, and that weight is going to be pulling on the head and straightening out the vertebra and the spinal cord of that person's neck. All right. There's also something called Crutchfield traction. Okay, and it's doing sort of the same thing, but instead of pulling on the bone, it's attached to the skin. Okay, but it will still have weights stretching out the vertebra. All right, so you guys, in another chapter, we've talked about precautions with somebody in traction. Remember, we never adjust the weight, we never move the weight. We always want that weight pulling and straightening that spinal cord. If we were to lift the weight up, then the spinal cord would not be straight anymore. All right, we might damage the spinal cord. All right, so we never adjust that weight without an order. We don't move it. We don't touch it. All right, other things that will help a spinal cord injury patient are special beds and cushions. All right, so we might have a patient in traction, or they might not be in traction, but they have a spinal cord injury. And we need to turn them, right? All right, and it might be hard to turn a patient with a spinal cord injury. You have to make sure when you're turning them that you move every bit of their spine together at the same time. Okay, so the head and the shoulders and the hips, they all have to be moved at the same time together to keep the spinal cord nice and straight. So that might be a little difficult to do. So they've made some special beds and cushions to help out with this. One that your book mentions, and there's a picture of that particular bed, is the roto bed. All right, and this is a bed that sort of has little braces or sections that hold the legs, okay, and also help the torso from sliding, okay, and this bed will rotate, okay, it'll rotate to one side, it'll rotate to the middle, and then it will rotate to the other side, kind of mimicking turning a patient. And this will take pressure off the different sections of the person's body, right? The left side, middle side, and right side. All right, so basically this bed sort of turns the patient for you. All right, and you guys, there's a picture of the Gardner-Wells tongs on page 447, and there's a picture of the roto rest bed, which is one of those rotating beds, okay, which turns the patient from side to side, and it's got a little sort of a cutout of a person's body, so the person doesn't slide while the bed is rotating. All right. Now, in addition to traction, all right, on page 448, you have a picture of a halo vest, all right, that your book calls a halo device. All right, it's sort of a vest that is attached to some rods, and those rods are attached to a round metal piece that goes over the head. All right, and this round metal piece has pins in it that can either just go to the skin, or they could actually go in and connect with the skull. All right, if the pins do go through the skin, you have to do pin care on this, which just means you wipe the pins every now and then with a alcohol swab. All right, and a lot of times they will go through the skin attached to the skull. All right, this halo vest has some advantages over the Gardner-Wells tongs. Gardner-Wells tongs, the patient is stuck in bed, okay? They're stuck to that pulley system, all right? They can't get up and walk around, all right? The halo vest, now the vest and those rods and the halo are holding the head and neck still, and the person can actually get up and walk around, all right? Or they can get up and use a wheelchair, all right? So you guys, you might see this with somebody that's got spinal cord shock, that sort of thing. All right, and it's being used while the spine is healing. All right. Okay, but this does have an advantage over the Gardner-Wells tongs in that the person can get out of bed, whether it's to be in a wheelchair, or, you know, if they could walk around, if they had use of their legs, all right, as well. All right, preserving cord function. All right, so you guys, when we looked at the anatomy of that vertebra, we said that little opening where the spinal cord goes through is the lamina, and you guys, we could have a laminectomy. All right, and we might do that when we want to fuse two spinal bones together. All right, so we could do a spinal fusion. Now, say in a motor vehicle accident or something like that, we not only injured the spine, maybe we injured the disc that provides shock absorption between the vertebra, right? All right, so we might have to remove the disc, okay, and fuse the two bones that the disc was in between. We might have to fuse them together. All right, so that would be a spinal fusion. All right, question 1. The average cost for the first year of a patient with paraplegia is approximately how much? All right, and the answer is D, about $500,000, right? $520, and I'm sure that cost has increased since the authors of your book wrote their book, right? All right, but the notes down here at the bottom say, okay, the average cost for the first year varies between a million and 6,400 for high tetraplegia. All right, and you guys, tetraplegia is our new word for quadriplegia. All right, so if you see a test question, maybe that says, what is paralysis of all four extremities? And you don't see quadriplegia, then the word just might be tetraplegia. Both words mean you have loss of all four extremities. All right, so the first year can vary from about $1 million to about $500,000. For paraplegia, all right, paralysis of the lower extremities. All right, so you guys, tetraplegia or quadriplegia means you lost use of all four limbs. Paraplegia means you lost use of your lower limbs or your legs, right? So you still have use of your arms, but you can't use your legs. Okay, question 2. One of the most serious and potentially dangerous problems for the spinal cord injury patient is. All right, all of those are possibilities, okay, but which one is most dangerous, you guys? And it would be the autonomic dysreflexia. The reason for that is because with autonomic dysreflexia, you could get dangerously high blood pressure, and you can get dangerously high tachycardia. All right, and those could lead to things like strokes and heart attacks. All right, now you guys, spinal shock is a form of spinal cord injury, but remember, you will get over it. You'll heal from that. Whereas if you have a severed spinal cord, that's going to be a lifelong loss of function. All right, so although spinal cord injuries may have spinal cord shock, it's not the most important. Okay, tetraplegia is important, but not as important as your life. Okay, and autonomic dysreflexia could put your life in danger after spinal cord injury, even if you're already tetraplegic. All right, and paraplegia, loss of your use of your legs, right? Okay, your life is more important, so that's why autonomic dysreflexia is more important. Remember, when we answer a question like this, we want to use our ABCs. All right, and autonomic dysreflexia, since it has something to do with our blood pressure, that's circulation. All right, C is going to be our top priority. Okay, the notes say one of the most serious and potentially dangerous problems for spinal cord injury patient is autonomic dysreflexia, an exaggerated response of the autonomic system to some noxious stimuli, and noxious means painful or irritating. So once again, you might want to write this down. That could be a full bladder. That could be a wrinkled sheet. That could be sitting on a Foley cord or tubing. Okay, and that could also be a bed sore. All right, anything that causes the patient irritation. All right, so we want to treat for pain if we think the patient's in pain, even if they can't feel it. How are we going to know that they're in pain if they can't feel it? Well, they might have vital sign changes, all right, caused by that sympathetic nervous system. So their blood pressure might be going up, their heart rate might be going up. That might mean they're having a reflex reaction to the pain, even though they can't feel it, and so we would give them pain meds. All right, second half of the slides. Okay, our objectives are: list the data to be included in the nursing assessment of a patient with a spinal cord injury. Identify patient problems, goals, interventions, and outcome criteria for the patient with a spinal cord injury. State the goals of rehabilitation for the patient with a spinal cord injury, and describe nursing care for the patient undergoing laminectomy. Okay, assessment. Monitor the patient's level of consciousness. All right, so you guys, whenever we have a neurological problem, and a spine is part of our neurologic system, we do neurochecks, right? And part of a neurocheck is LOC, level of consciousness. All right, so we want to measure the patient's level of consciousness. All right, we're going to ask them, do they know where they are? What's the date? What's the day of the week? Something that shows us that they're alert and oriented. All right, in addition to that, we'll do vital signs, because we're looking for things like autonomic dysreflexia, right? We'll do respiratory status, because remember, if they have a C5 or above, we're worried about respiratory status, even if they're not on a ventilator. And they wouldn't be if they had a C5. They would be if they had a C4. Okay, but we want to make sure they're breathing well, they're clearing secretions, all right, which means we might have to suction them to help clear secretions. All right, so we might do suctioning of the mouth. We might be calling the respiratory therapist to do a deeper suction. Okay, but we need to help those patients clear their secretions. All right, we might be giving them nebulizers and things like that. All right, motor and sensory function. All right, so we want to assess this to see, where their loss is. That would tell us what level spinal cord injury we have. All right, if the patient's in spinal shock, that might tell us when we compare their baseline assessment with our new assessment, it might tell us, are they getting some of their functioning back with spinal shock? All right, and you guys, we do their I's and O's, intake and output. All right, especially if they're voiding for themselves. We want to make sure their bladder doesn't get too full. We want to make sure what we're putting into them is coming out, right? Okay, if they have a Foley, we want to do the same thing, right? We want to keep track of their ins and outs, right? We want to do accurate record keeping when we do that. All right, interventions, inadequate oxygenation. Okay, remember, if we have a injury above that C5, we're very worried about oxygenation, especially if they're on a ventilator, right? We're going to have a readout that's telling us everything going on with the ventilator. All right, now a med-surg nurse is not going to have to know how to interpret all the things on a ventilator. All right, but maybe someday you're going to be in an ICU. You want to be an ICU nurse, things like that. You will eventually learn how to read everything on that machine. All right, but we want to do things, that we would normally do. We want to do their O2 sats, right? We at least want to make sure the ventilator's on and it's working. All right, if they're not on a ventilator, okay, they still might have, with a lower spinal cord injury, they may be able to use their diaphragm fine, but they have maybe some issues with their accessory muscles, their intercostals, right? And you can have issues with those on lower spinal cord injuries. All right, so we want to make sure they're breathing well enough to oxygenate their tissues, right? So we're going to do the things we would normally do, and one of those would be to check their pulse ox. Maybe we'll check their capillary refill. All right, so we're going to keep an eye on their oxygenation. All right, potential for injury. That could be anything, right? That could be injury from autonomic dysreflexia. That could be injury from a bed sore. That could be injury from not getting enough oxygen, right? Almost everywhere you could have an injury. All right, risk for injury related to the autonomic dysreflexia. Once again, that could be dangerously high blood pressure, dangerously high heart rate, causing an injury like a heart attack, like a stroke, like heart failure. All right. Okay, potential complications related to immobility. That might be a bed sore. All right. It might even be now we have more fluid accumulating in the lungs, right, from immobility. Could even be constipation, right? A lot of spinal cord injury patients have issues with constipation, and we might have something like a stool softener that we give them. All right, loss of bowel control. So they might be incontinent of bowel, okay, or bladder. Okay, and difficulty voiding, especially if they had bladder issues. All right, interventions. These are the beginnings of nursing diagnosis. Okay, potential for infection. Okay, you guys, especially of the lungs. Remember, a lot of patients after spinal cord injury, after they've had it for a while, they could die from pneumonia. All right, so that's an infection, right? All right, infection may be from the wounds that caused their spinal cord injury. Maybe they were in a motor vehicle accident. Okay, maybe they have an open spinal cord injury. We're worried about infection. Elevated body temperature. All right, because they may lose the control of their ability to regulate their body temperature. All right, impaired LDLs because they can't use their arms or their legs. Okay, altered sexual function. All right, because if the injury is above the sacrum, they're not going to have sensation from sexual activity. Now, your book says men still may get an erection. All right, but they won't be able to feel anything. Okay, and women can still have intercourse. They're just not going to feel it. And women can still get pregnant. All right, and depending where the injury is, when it comes time to deliver the baby, they might be able to have contractions of the uterus. But once again, they won't feel those contractions. They won't feel the labor pains. All right, but we still might be concerned about something like autonomic dysreflexia. All right, so we probably would still do interventions for pain. All right, inadequate coping. Of course, if you found out you're going to be in a wheelchair for the rest of your life, you're going to be hooked up to a ventilator for the rest of your life. You might not cope very well. All right, and inadequate self-care. You may have to learn how to catheterize your own bladder, stimulate your own bowel movements. All right, take medicines for your muscle spasms. Okay, and you might not, especially if you have inadequate coping, you might not be able to psychologically deal with all that care you might have to give yourself, right? So inadequate self-care. Okay, rehabilitation. Activities that assist individuals to achieve the highest possible level of self-care and independence. All right, so you guys, when they do eventually go maybe to physical rehabilitation, if they still have use of their arms, they might be doing things like weightlifting and things like that. All right, and they probably will have to do a lot of exercise, a lot of muscle building, if they do have use of their arms, because eventually they're going to want the patient to maybe transfer themselves out of a wheelchair onto a chair, onto a toilet, in and out of bed, okay? And since we want patients to have the highest level of independence, we'd have to be teaching them how to do all these things. But first, they're going to need the upper arm strength to lift themselves in and out of a chair, in and out of bed, right, to a chair. All right, so first in rehabilitation, they're going to build up those muscles, okay, if they're going to be doing things like that as part of their self-care. All right, a well-organized interdisciplinary team that can assess all aspects of function. All right, interdisciplinary, that just means we're going to have people from different disciplines or different professions. All right, so that means doctor, nurse, physical therapist, occupational therapist, speech therapist, dietitian, social worker, psychologist, and counselor. All of these people are going to be on the patient's team, all right, and work together to help the patient. For instance, the dietitian might help the doctor order the proper diet for a patient. All right, the speech pathologist might assess swallowing ability in a patient. All right, a social worker might get insurance that will help pay for the hospital stay, pay for the speech therapist, pay for the physician. All right, pay for a psychologist to help with, maybe that ineffective coping that the patient might have. All right, or a counselor as well. All right, patient and family must be emotionally and physically prepared to make adjustments. Remember, the family might now have to do a lot for the patient. They might have to turn the patient. They might have to stimulate bowel movements. They might have to deal with a feeding tube. All right. They might have to deal with medicating the patient for pain, medicating them for muscle spasms, those kind of things. All right, so you guys, care of the patient having a laminectomy. All right, so you guys, this is a surgery on the spine. And so, of course, we would do all of our things that we would do for any surgery patient, right? We're going to take vital signs before and after the surgery. We're going to teach our patient anything we want them to know before surgery, things we want them to do after surgery. Okay, maybe things like how to use an incentive spirometer, okay, that we're going to treat for pain, okay, that we're going to be doing vital signs frequently, all right, that sort of thing. All right. Okay, and also, any things that they might have after surgery. Most of the time, you don't need to be in traction after back surgery, but if they were going to be in traction, we would tell them about that. All right. Okay, so you guys, after surgery, we'd assess for sensation. You guys, when you're doing a back surgery, there's always a risk you cut nerves in the back area in the spine. All right, so we're going to have our baseline assessment when we assess things like sensation, and we're going to assess that again after surgery. All right, to see where is their sensation at now. All right, so we're going to test for sensation in their hands, their feet, okay, different areas of their skin. All right. Okay, potential for injury after laminectomy. After any surgery, there's always risk for infection. Okay. All right, so we're going to assess the dressing, assess the surgery area. All right, we're going to do as much respiratory hygiene as we can. If the patient is able to use incentive spirometer, we would have taught them that before surgery. We're going to have them use it after surgery. All right, inadequate circulation. You guys, with any surgery, we have risk for things like DVTs. Okay, deep leg or deep vein thrombosis in the legs. All right, the patient would have been in a cold room during surgery. All right, that might slow down circulation. The patient is immobile. All right, that might slow down circulation. All right, so we're going to assess circulation. Once again, that might be cap refill in the fingers and the toes. Okay, it's going to be looking at their color of their skin. It's going to be taking their blood pressure. All right, it's going to be doing their vital signs, heart rate, and all of that. Pain, we're going to treat it, whether they can feel it or not. Because remember, we're worried about things like autonomic dysreflexia. Okay, difficulty voiding, as we've talked about. Risk for complication, as we've talked about. If you're immobile, okay, you're at risk for complication. Okay, impaired mobility, because you haven't moved around in the surgery. Maybe after surgery, you're not able to move around. Remember, most surgery patients, we want to get them up walking as soon as we can. In this case, we might have a patient who's not able to walk. All right, and then inadequate knowledge. So we do our pre-op teaching, we do our post-op teaching. All right, post-op, things like medications they're going to be taking, okay, pain control, things we're going to be doing for them. All right, so you guys, that's the end of our lecture. All right, now things you should write down, because they're things you might see again. All right, so you guys know where different injuries at certain vertebra, okay, are going to cause certain problems. You should, of course, know the ones that cause respiratory problems, meaning the patient can't breathe on their own. Okay, that's going to be anything above C5, right? They're going to be on a ventilator, most likely. Okay. All right, remember, at or above T6, we're going to have issues with autonomic dysreflexia. All right, so at least know those important two areas. When do we need a respirator, a ventilator? Okay, when do we have to worry about autonomic dysreflexia? All right, you guys, other things you should know are how to prevent bed sores in your patient. Okay, because bed sores are painful. Bed sores are something that could be triggering autonomic dysreflexia. We want to prevent bed sores in any patient, and that includes patient with spinal cord injury. All right, so that means turning them, okay? It means keeping their skin dry, especially if they're incontinent. All right, you guys, it means pillow for their feet, okay? Because a lot of times they don't have muscle control of their feet. They can't move their feet. So you guys, we want to float their heels, because a lot of times bed sores happen at pressure points, and your heel is a pressure point. All right, so we want to float the heels on a pillow, okay? All right. All right, we also want to keep in mind that if a patient is having spasms and, it hasn't been too long since they've had their spinal cord injury, they haven't learned yet that spasms are a natural thing that happen after spinal cord injury. We want to let them know that doesn't mean they're getting control of their foot back or their leg, okay? Those spasms are involuntary, right? And they're more of a reflex. They're not signals coming down from the brain. They're signals that have been originated in the spine, okay? All right, also keep in mind that things that are going to help not make a spinal cord injury worse are things like having the patient in traction, okay, keeping their spine aligned and straight while it's trying to heal. All right, and also providing the patient with steroids. Okay, remember those steroids are going to, after the injury in the acute phase, they're going to stop inflammation, and sometimes inflammation causes cellular damage. So if we stop the inflammation, we stop the cellular damage. All right, so we might be giving the patient something like methylprednisone or solumedrol or one of the other steroids. All right, you guys, that is the end of this lecture. All right, hope you're enjoying your 3-day weekend. See you next time.